Hello, I'm Dr. Tran from the Manukian Division of Digestive Diseases at UCLA and UCLA Santa Monica Hospital, and I'm the Chief Medical Officer of Glimpse Bio. Today, I'll be talking about barriers in viral hepatitis in pregnancy, working towards viral elimination. So the WHO has set very clear standards for where we need to be to meet a 2030 target for elimination of hepatitis B by 2030. I think that they appropriately said that we need to have 90% of infants have hepatitis B birth dose vaccination, 100% of donations be screened for hepatitis B, 90% should have access to safe injections, and the testing targets that 90% of people should be aware of their infection, and then 80% of people who are eligible for treatment with chronic hepatitis B should be treated. So setting these goals several years ago to try to eliminate viral hepatitis, I think was important for us to be able to have these goals globally. And we can see here from this slide of the global timing of hepatitis B elimination, we've done well in some regards, in that in some of these countries that you see listed on the image on the left, that the prevalence amongst 5-year-olds in many of these countries being low, we've achieved that target and will probably be able to achieve that by 2030 of having low prevalence in young children. However, you can see in the blue and in the orange, we still have many opportunities where the diagnosis, treatment, and reduction in mortality will likely not achieve the target that the WHO has set by 2050. And you can see by different countries here on the right that each country in the timeline of where we think we might meet these global elimination goals, it's going well beyond 2050. So there are many countries that still require a lot of improvement, particularly in treatment and mortality, despite our success in some areas. So when we look at hepatitis B with mother to child transmission, we think that perinatal transmission is believed to account for up to 35 to 50% of hepatitis B carriers globally. So prior to giving vaccination or immune prophylaxis, it was clearly very high rates of children becoming chronically infected. And even with standard immunoprophylaxis with vaccine and HBV, remaining 8 to 30% of children born to highly viremic mothers can still become chronically infected. We also think that intrauterine infection can occur as well. And so we don't know the precise mechanism. There still needs to be a lot of information on the mechanism of intrauterine infection, but really perinatal transmission is really the biggest bulk of how hepatitis B is still transmitted from mother to child. In Vietnam, hepatitis B, viral hepatitis is the third leading cause of death and accounts for 7 million hepatitis B chronic infections worldwide. So Vietnam still has a very high prevalence of infection. And I think we all know that the progression to chronic infection, meaning when someone gets infected, their chance of having it become chronic instead of clearing the infection is very related on the age at of the time of acute infection. So if you are exposed to hepatitis B at birth, then there can be a very high chronic infection rate, as high as 90% if they haven't been vaccinated. Or in older children and adults, it may be less than 5%. So age-related chronicity, so the chance of it becoming chronic is very related to the time of exposure. That's why mother-to-child transmission is so important to block that time, because at that young age, that's when becoming chronic is so much more high risk. And when you see the birth dose vaccine, of getting that vaccine in at the time of birth, 19% out of 47 countries in WHO Africa admit or do the birth dose vaccine. So unless you get the vaccine in at the time of birth really early, you can see that the chronic infection rate can be very high if the baby is exposed to hepatitis B. So hepatitis B and maternal child transmission, mother to child transmission in Vietnam. Well, we think that the prevalence of chronic hepatitis B in Vietnam is around 10%. And the prevalence of hepatitis B in pregnant women is around the same. So it's not like pregnant women are safer or somehow have lower rates of hepatitis B. It's still quite high, 1 in 10. So the incidence of new hepatitis B infection in the population of hepatitis B in Vietnam is coming mainly from in mother to child transmission. And that may be as high as 10 to 20% of the population are getting hepatitis B through this route. So the government, I think, and the nation recognized this and created some national programs to try to reduce hepatitis B. And in 2004, they instituted a 4-dose hepatitis B vaccination schedule. So 4 instead of many countries do 3. And in 2014, they recommended HBV, which is passive vaccination, giving the immune globulin as recommended, and antiviral treatment, oral therapy for pregnant women with high viral load. So in the women who have highest viral load, and I'll show you data on that, they may be at high risk of transmitting hepatitis B to their child, even if the baby gets vaccination. So there are some strategies to try to even reduce that even further by looking at the stratification of the highest risk pregnant woman. So what are the risk factors for hepatitis B mother to child transmission? I think there are clearly some viral factors, virus levels being very high, E antigen levels being positive. There's some data on genotype B and maybe S mutations. There are also mom factors or maternal factors of threatened preterm labor. So if mom has a lot of difficulty with pregnancy or severe prolonged urine contractions, obviously more chance of blood mixing with baby may have an increased risk of transmission of hepatitis B to baby, as well as more traumatic delivery, potential invasive procedures like amniocentesis. And there's a lot of question around breastfeeding, especially if the moms have a lot of injury to the nipple or to the breast area with skin breakdown. That could also lead to potential transmission. But in the end, despite all of these potential risks of both virus and mom, probably the strongest thing has been the mom's virus levels. So serum hepatitis B DNA has been identified as the single most important predictor and independent risk factor for mother to child transmission. So virus level in the mom is probably the most important factor, as you would imagine, for transmission risk to baby. And we saw that initially when we first looked at risk factors, we didn't have, back in the, many years ago, we didn't have virus levels. So we used E antigen as a marker of activity, of virus activity, because usually patients who are E antigen positive have higher virus levels. And you can see here from this study, looking at E antigen, that the patients who had transmission of mother to child transmission rate that was very high, those were usually the patients who had E antigen positivity. So maybe it was transient, that didn't make as much difference, but persistent infection for sure. Without vaccination, you can see here that the E antigen positive moms transmitted the highest. With vaccination, that goes down to less than 10%. So you can see here that vaccine plus HBV really does a very good job at reducing transmission in moms who have active virus in the form of E antigen positivity. But when we started doing DNA testing, we could really see a little bit better data on that. So when you look at mother to child transmission in all infants who are hepatitis B from moms who are hepatitis B positive, the rate was 2.9%. In the E antigen positive mothers, it was 6.6%. But when you look at virus, you can see here that the moms who had greater than 10 to the 8th copies per ml, and remember that these infants all received vaccination. So obviously if they didn't receive vaccination, these numbers would be much, much higher. But these infants received vaccination within 12 hours of birth and HBV. So they received both types of active and passive vaccination. And you can see here that even with that, moms who have very high virus have an 8.5% mother to child transmission rate. So that led to a lot of discussion about what to do about these mothers who have high viral levels and how we can reduce this even more. So further study on this risk factors for mother to child transmission. Remember that babies receive the vaccine plus HBV. They receive another HBV in this study. They got the full vaccine schedule, and they checked the hepatitis B DNA levels at birth, at 8 weeks of life, and then at 48 weeks, so 1 year. And they really wanted to look at what were the subtle other factors that may be contributing to failure of the vaccine. And of course, the vaccine rate was, as we saw with the previous study, the higher the mother's vaccination, the higher the mother's virus level, the higher the risk of maternal to child transmission. So the odds ratio was 8.92 as an independent factor for vertical transmission. But when you look at other factors in that study, because they really followed these mothers and these children very closely, you can see here that antepartum hemorrhage, so bleeding prior to birth, meconium-stained amniotic fluid, and oligohydramnios basically, birth-related complications was statistically significant in the univariate analysis on potential other risks. So virus in mom is really the strongest risk, but when you have traumatic issues around the time of birth, that can really lead to potential transmission from mom to baby as well. What about the mode of delivery? So it's a very common question about delivering vaginally versus delivering by cesarean section. So I think this is one of the best studies that have been done because it's a prospective study, not a retrospective study. This prospective study of 1,384 women, all the babies received HBV plus vaccine. They found, luckily, the overall incidence of transmission was low at 1%. But C-section versus vaginal delivery, there was a statistically significant difference. In elective C-section, 1.7% versus vaginal delivery, vaginal delivery 1.7% versus 0.5% for C-section. So that was statistically significant. And in the fully adjusted model for elective cesarean was associated with a decreased risk of mother to child transmission in hepatitis B. So high viral load, particularly this seemed to be better with C-section versus vaginal delivery. So once again, maybe in the moms with high virus, that's where you may want to consider or think about the risk benefit of elective C-sections. And when we look at the meta-analysis of giving hepatitis B, hepatitis B immune globulin, and hepatitis B vaccine on occurrence of hepatitis B in newborn infants, it's very clear that if you do nothing, that's obviously the highest risk. If you give HBV, that reduces the risk, that's immune globulin. If you do vaccination, that lowers the risk as well. But the combination of the two, we call that passive active vaccination, will give the best chance of not transmitting hepatitis B from mom to child. So transmission still occurs, but giving the combination active passive vaccination seems to be the best potential protection for the baby. So if the mom has really high virus, what can we do? What else can we do to prevent transmission? So in this study that was published in the New England Journal now 5 years ago, 200 e antigen positive mothers, so we know they have active disease based on e antigen, and the virus levels were over 200,000 IUs, or 1 million copies per ml, were randomized 1-to-1 to either usual care or they received oral tenofovir from 30 to 32 weeks of gestation until 4 weeks after delivery. So basically they got antiviral therapy in the 3rd trimester to bring down their virus so that at the time of birth, they would have a lower viral level. And you can see here that per protocol and intention to treat, you can see that statistically, those mothers who had high virus were able to reduce transmission of the baby from getting hepatitis B in those who received oral antiviral therapy versus control. So I think it's important to note that moms who have high virus, there are things we can do to try to prevent the risk. Even if baby gets vaccination, there's still some risk. So reducing that risk is important. And when you look at safety of medications, so if you decide that the mom has high virus and you want to try to put the mom on antiviral therapy in the 3rd trimester to try to reduce the risk, what is the safety profile? And the database for safety amongst women who take antiviral pregnancy registry, this is the registry here. You can see here that lamivudine and tenofovir have a prevalence rate of birth defects of between 2 and 3%. Tenofovir has a smaller number of patients, it's around 4%, and that's compared to the background rate of birth defects being between 2 to 4%. So what that basically tells you is that these antiviral therapies are around the same baseline of birth defects as you see in the general population who are not treated with antiviral therapies. So the safety data has to be discussed very closely with the patient and make decisions about that, but it appears that the antiviral therapies are comparable in terms of birth defects or birth rate defect rates compared to the general population. So in summary, global elimination of hepatitis B will require broad implementation of mother to child transmission strategies. So mom to baby transmission is still a very, very, unfortunately, still a very important mode of transmission of hepatitis B. It's still, that's one of the ways that it's commonly transmitted. Birth dose vaccination is the most effective strategy. So giving the vaccination at birth around the world in every place that we have hepatitis B is the way to try to eliminate hepatitis B from this world. But those at highest risk, meaning a mother with high virus greater than 200,000, we should be thinking about how to reduce her risk even more. So consideration about third trimester antiviral therapy, you saw in that New England Journal paper, to put patients on third trimester oral therapy can reduce the risk even more. Consideration of elective cesarean section, and then certainly trying to give both the combination of hepatitis B immune globulin and vaccination for the infant. Thank you.